Welcome, everyone, to Season 2 of the TIMI Talks podcast. I'm Nick Marston, here with my co-host David Berg, and on today's show, we'll be joined by Duke cardiologist and clinical trialist Dr. Rob Mentz to discuss iron supplementation in heart failure and the HEART-FID trial. Well, it's great to be back, David. I'm really looking forward to this season of TIMI Talks, our second season.
Yeah, absolutely. We have a great lineup planned for the fall. But of course, before we get into that, there were some important developments in the Marston family during our summer hiatus that we need to cover first.
That's right. Yeah, thanks, David. We had our second child and our first baby boy 2 months ago. So I guess I'm following in your footsteps with the older girl first, followed by a younger boy. I'm soliciting any advice that you may have.
Well, first off, huge congratulations to you and your family on the new addition. That's really amazing news. And second, I guess Beyonce already told you who run the world.
Yeah, my wife will appreciate that one. Um, so, parenting advice, trial advice, we really cover it all here on TIMI Talks. And speaking of new children, I know Mark Sabatine always likes to refer to our trials as our children, and we have a new addition to announce in that regard as well.
Right.
This new TIMI trial is actually related to a conversation we had with Mark back on our post-ACC episode during season 1. I believe it was episode 2. And in that episode, we discussed the promising phase 2 data for the oral PCSK9 inhibitor from Merck, which was both safe and effective with a 61% reduction in LDL cholesterol. Up next for the program then will be the phase 3 cardiovascular outcomes trial, which TIMI will be partnering with Merck to design and conduct what will be a pivotal trial and really important for the field of cardiology, preventive cardiology, and how we manage patients with ischemic heart disease.
Yeah, no, really exciting. I mean, it's always an exciting time around the office when there's a new trial announced. This trial is obviously no different, and I think there's really a lot of enthusiasm for this drug class and an oral formulation. So it's going to be called Coral Reef Outcomes, TIMI 77, and the plan is to enroll about 14,500 high-risk patients with a primary endpoint that being the composite of death from coronary heart disease, myocardial infarction, ischemic stroke, acute limb ischemia or major amputation, or urgent arterial revasc. So Nick, preliminary thoughts?
Well, it really is exciting, and there's no question that having an oral option for PCSK9 inhibition will be a great tool to add to our tool belt. And when you think about it, if you could add that then to a statin and have two oral medications that in combination could potentially achieve an 85% reduction from baseline LDL cholesterol, it could be a real game changer. I think the challenge of this trial could be finding patients who don't already meet criteria for or an indication for a PCSK9 inhibitor. But that can be overcome by certain design elements like broadening the population beyond just those with established ASCVD, and so including those who are high risk, and also going into other countries, expanding the global footprint where there may not be as much penetrance of monoclonals and inclisiran. So this is no doubt going to be a practice-changing landmark trial, and as you said, we'll certainly keep our listeners updated as things go along.
Yeah, much more to come on that front for sure. But first, as you said, IV iron and heart failure. So I am very excited to welcome today's discussant, Dr. Rob Mentz, who is the chief of the heart failure section at Duke University Medical Center. And as you mentioned before, he's a clinical trialist with the Duke Clinical Research Institute, or DCRI. He's also a journal editor, serves as the editor-in-chief of the Journal of Cardiac Failure, which is the official journal of the Heart Failure Society of America. So wears a number of different hats. Dr. Mentz is the first author of the HEART-FID trial, which was presented at the European Society of Cardiology Congress in August and was simultaneously published in the New England Journal of Medicine. So let's go ahead and bring Rob on the show.
Well, welcome to the TIMI Talks podcast, Rob. It's really great to have you on the show.
Thanks so much, Nick. It's good to be with you and David. I'm looking forward to the discussion.
Yeah, as Nick said, we're thrilled you could join us. You certainly had a banner year in clinical trials with at least 3 late-breaking clinical trial presentations at major professional society meetings in the last 12 months. And so So we thought it was, an invitation to come on TIMI Talks would really be the icing on the cake.
No, thanks so much. It's fun to join you, and I'm looking forward to chatting and getting to know you all a little bit better, and excited to see all the great work you're doing as well.
Well, awesome. Well, thanks for joining us. So, before we dive into the trial design, we always love to hear a little bit about how trialists became trialists. So I guess to get things started, I was hoping you might tell us about, I guess, how you got interested and involved in cardiovascular clinical trials.
Yeah, thanks so much. So I was fortunate to come to Duke for my cardiology fellowship, and from the earliest days, I was fortunate to have just tremendous mentorship, and I was always intrigued and fascinated by clinical trials. This idea that you could answer a fundamental question and help improve patients' lives in a really rigorous way. And it was through my mentors they actually got me involved in some early clinical trials, a study called Tactics, which was looking at tolvaptan in heart failure with Mike Felker and Chris O'Connor, Mona Fusat, and many others. And it was learning the day to day. It was helping design the trial, execute it both at a site level and then actually across multiple sites. So that got me more and more interested in it. And it was from there that actually one of my mentors, Adrian Hernandez, got me involved in one of the large global diabetes studies, this Excel trial looking at a GLP-1, which lo and behold now is the years have advanced and the data have evolved. Lots of excitement in that space across cardiology. So it was really through exceptional mentorship that I was so fortunate to get involved in these trials and to learn about how to execute them and disseminate them and then mentor the next generation. So it's been really fun.
Well, that's really interesting to hear, Robin. And I think the role of mentorship is something that's a thread and theme with everyone that we talk to. Key to have mentors who are involved and can get junior faculty and fellows involved. So that's great. There's so many different topics we could potentially cover with you, as David outlined. But we specifically wanted to bring you on the show today to discuss iron replacement therapy in heart failure, which is a topic that comes up all the time on rounds. Residents and fellows always bringing this up, asking, what's the latest data? And that's the clinical question that you and your colleagues addressed in the HEART-FID trial, which was presented at the European Society of Cardiology in Amsterdam and simultaneously published in the New England Journal of Medicine. And so taking a step back, we were wondering if you could provide a little context for, why iron deficiency is a therapeutic target of interest in heart failure.
Yeah, thanks so much. So this is something that I've learned a lot from my colleagues, whether it's the renal folks or hematology folks. And as we look at iron deficiency, realizing how common this is in patients with heart failure, I think a really important message is flipping it on its head a little bit. Many of us in our training, we were taught to think when you see anemia, think iron deficiency. And really, a key message is when you see heart failure, think iron deficiency. And it's really regardless of anemia status. It's so common, especially as you're noting in the hospital. So upwards of 50–60% of our patients in the hospital with heart failure have iron deficiency. We can talk through a little bit about the different definitions, but some key messages are, yes, it's common. And people often say, well, why? Why do we see this so commonly? And it's certainly multifactorial, but as we think of the different steps, many patients with heart failure, there's a reduced intake of iron. And then even if their diet includes enough iron, in the setting of heart failure, it's not absorbed as well. And then even if it is absorbed, there's challenges with actual sequestration. So the iron in the body can actually not be mobilized as well in patients with heart failure due to inflammation and hepcidin and some of those important pathways. And then finally, there's actually increased loss of iron, whether it's through bleeding. Many of these patients, as you know, have concomitant atrial fibrillation or on blood thinners. So it really is the full gamut of why patients with heart failure have iron deficiency. And then some really nice early work showed that iron deficiency leads to worse symptoms, worse functional status, and actually worse outcomes, increased mortality and increased hospitalization. So putting all that together, years and years of research have helped us understand that iron deficiency is common, associated with worse outcomes, and really impacts the life of our patients with heart failure.
Well, thanks. That's certainly very helpful background. As we start to transition to the trials in this space, there were multiple prior trials looking at iron supplementation in heart failure, including AFFIRM, AHF, and Ironman. Both of these just missed statistical significance, but on aggregate appeared to show benefit from iron IV supplementation. And so, how did those prior trials inform the design of HEART-FID?
Yeah, thanks so much. So maybe even taking a little bit of a step back, there were some earlier studies, FAIR-HF, CONFIRM-HF, AFFECT-HF, a number of really nicely conducted, smaller, couple hundred patient studies that looked at patients with heart failure with reduced ejection fraction and iron deficiency. Then by giving IV iron and then following important function and feel endpoints, so quality of life, 6-minute walk distance, important improvements with IV iron as compared to placebo in those studies. And then, as you nicely noted, two larger studies of over 1,000 patients with AFFIRM AHF that showed a nominal reduction in cardiovascular death and total heart failure hospitalization with ferric carboxymaltose, one specific formulation, and actually that was EF less than 50% in the hospital with heart failure. And then Ironman, a study that was reported out just about a year ago now at AHA last year, actually looked at a different IV iron, ferric durisomaltose, and that was both in the hospital, out of hospital, but it was reduced ejection fraction, and pretty strikingly similar results showing this significant reduction in terms of heart failure hospitalization, narrowly missing the primary endpoint of cardiovascular death and total heart failure hospitalizations. And both of these trials were dramatically impacted by COVID, meaning the execution and the clinical outcomes. So some of the pre-specified analyses, as you're getting at, did suggest that when they adjusted for COVID, the trials were at least numerically positive as well. So it's with that background where you've got important function and feel endpoints, some suggestion of a heart failure hospitalization reduction, that we designed and executed the HEART-FID trial, which was designed to be ideally the pivotal trial in heart failure with reduced ejection fraction with IV iron, looking at ferric carboxymaltose, again in the setting of iron deficiency, and then giving this therapy every 6 months to try to improve clinical outcomes. And we'll get into, I know, a number of the details around this, but it was designed importantly in discussion with the FDA as one pivotal trial, which led us to have a higher bar in terms of statistical significance, as we'll get into, and importantly talk through some of the clinical implications.
Yeah, that's really helpful context, and I think as you said, there was sort of a groundswell of both preclinical and then clinical data that suggested its benefit, and sort of really nicely set the stage for HEART-FID to come answer the question. You touched on a couple of the design aspects, and one of the design aspects that I think is worth spending a little time on is the primary endpoint, actually, which was a hierarchical composite of death within 12 months after randomization, hospitalization for heart failure within 12 months after randomization, or change in 6-minute walk distance from baseline to 6 months. So I guess from a study design perspective, I think there's a couple interesting aspects of that particular primary endpoint. And the first is just, I guess, the concept of hierarchical endpoints in general, because that may be a little bit less familiar to some listeners. So Rob, I guess in generic terms, I wonder if you might comment on, why would you use a hierarchical endpoint in a clinical trial, and maybe why you guys chose to use one in HEART-FID?
Yeah, thanks so much. So many of us are familiar with these more traditional or historical endpoints, which are time to first events, things like cardiovascular death or heart failure hospitalization. So a composite endpoint, where importantly, each of these, whether it's death or a heart failure hospitalization, they're given the same rank as you compare different treatments or interventions. And some of the key details that are nice about a hierarchical endpoint is that it prioritizes those, and certainly there's variability and not always agreement, but in general, it allows prioritization of the more severe endpoints, the most severe components. So in this case, we chose all-cause death is the top of our hierarchy. So what this allows is then you compare patients in each, the treatment group and the placebo group, with respect to first, death, And some have said, trials have also looked at cardiovascular death specifically, but we ultimately decided on death at 12 months because we felt that that best captured the patient's severity of illness. And then so you first compare across death, and if neither patient died, then you would move on to the next level of the hierarchy, which was hospitalizations for heart failure in this case. And what's nice here is that it allows, again, not just the first hospitalization, but the total number of hospitalizations. So you're starting to put together this endpoint that incorporates elements of severity or the ranking, and then it also has the totality or a recurrent event type analysis. But then a really nice piece is that it allows, in our case, to actually include 6-minute walk distance at 6 months. So this is a functional status measure. The nice component here is that it then allows more patients to contribute to a primary endpoint. So in contrast to many of our studies where thankfully a minority of patients have events in terms of their clinical course, but it means that you actually don't have all patients contributing to a primary endpoint and giving data with respect to that outcome measure. So that was some of the rationale and the reasoning behind this. And you might say, well, why did you do 6-minute walk distance at 6 months and not 12 months? And some of the rationale there was based on our prior experience. We knew that over time we would have more missing data based on trials like HF Action and exercise training trial, that as you got further out, you had more missing data for 6-minute walk distance. So this was designed in discussion with the FDA to capture the patient journey, looking at the priority of death, then total hospitalizations, and then allowing patients that didn't have a clinical event to contribute to a primary endpoint by this functional status measure.
Yeah, I mean, that's incredibly helpful. And I think certainly there has been a lot more interest, I think, in hierarchical endpoints for exactly those reasons, the opportunity for, for patients to contribute to an endpoint, shy of actually having hard clinical events. I think you kind of alluded to this a little bit, but there's, of course, multiple different surrogate endpoints that you may have picked as sort of the anchor of this hierarchical composite. Because in the field of heart failure, there are a number of kind of validated surrogate endpoints that may reflect health status or functional status, the feel and function endpoints, as you said. And so for those who may be less immersed in the world of heart failure trials, I wonder if you might touch on how you think about selecting which is the right surrogate endpoint, and I guess why you decided on 6-minute walk distance in this particular trial.
Yeah, appreciate that. And there's lots that went into this, as you can imagine. But early on, we actually were exploring having KCCQ, or Kansas City Cardiomyopathy Questionnaire, a health-related quality of life measure that's commonly used in clinical trials and is an approvable component or endpoint. Ultimately, we landed on 6-minute walk distance as functional status, sometimes referred to as an exercise capacity measure, based largely on the prior studies with IV ferric carboxymaltose, or FCM, which showed this large clinically significant benefit of upwards of 30 meters in 6-minute walk distance. So that was some of the rationale based on prior data that it is approvable. And those will be some of the key measures, whether it's a quality of life or a 6-minute walk distance that we use in heart failure. And there are certainly some other measures, but those are probably the two most common. And they have pros and cons, but I think are the most well accepted and broadly known across the clinical and research community.
Well, excellent. So I want to pivot to the trial results, but before we do that, could you just maybe briefly remind the listeners what exactly or specifically the intervention was, both in terms of the iron formulation and kind of the dosing or scheduling, and maybe why that was chosen, because I know you mentioned it was different in some of the prior trials.
Yeah, thanks so much. So in HEART-FID, what we looked at was IV ferric carboxymaltose, or FCM. Patients had heart failure with reduced ejection fraction and iron deficiency. And that was defined based on this definition that had been used in prior FCM trials, and it had been incorporated into the guidelines. So it's a ferritin less than 100 or 100 to 300 with a TSAT less than 20. And this allows for those with that ferritin less than 100, where we think of more absolute iron deficiency. as well as those that have more inflammation and may have a higher ferritin, but have a TSAT value that's less than 20%. And we can spend more time talking about that, but it was because of the prior trials as well as the guidelines that recommended that definition. And then the intervention itself was patients were given FCM. It was weight-based, but for those, the vast majority greater than 50 kilos, they would get 750 milligrams IV, and it was separated by 7 days. So basically they got 750 at baseline and then 7 days later. And then every 6 months, based on their iron indices, they would either get additional iron if they still met the iron deficiency criteria, or they would receive placebo if they were iron replete. And that continued during the long-term follow-up with a median of 1.9 years. So it really was testing this repletion strategy, and it does differ some from the earlier programs. And I would underscore a couple key things. One, some of the earlier studies gave different dosing and at different time points. The reason we gave it this way was based on the label of FCM here in the United States. And that's actually changed now before we even reported our trial out. There is actually a label indication for exercise capacity with FCM. But I would summarize the primary results by saying we recruited a diverse population with heart failure with reduced ejection fraction, with more than a quarter here in the US were Black individuals, more than a third women. Importantly, as we looked at the iron indices, and we may return to this, but actually the baseline TSAT value was higher than some of the earlier programs. It was in the 20s, whereas Affirm and Ironman, it was 15%. So we're already starting to put together a little bit of a difference in dosing, some differences in the patient characteristics. But we did show that FCM repleted iron stores. And then as we looked at that primary endpoint, this hierarchical composite, we saw fewer deaths with FCM. We saw a numerical reduction in heart failure hospitalization and a modest improvement in 6-minute walk distance. So a 4-meter benefit with FCM. So putting all this together, we were neutral with respect to the primary endpoint because this resulted in a p-value of 0.019, narrowly missing our pre-specified level of 0.01, which was based on one pivotal trial. But I put this together as highlighting that we did see each of the components favoring FCM, but ultimately just more modest of a treatment effect with this intervention and these baseline characteristics. And then finally, I would note that in pre-specified responder analyses looking at 6-minute walk distance, we did see an increased odds of response of 10 or 20 meters with FCM of more than 20% increased odds for each of these different thresholds. So I think really just putting together this story that building upon the earlier studies, we did see benefits just more modest and not meeting our pre-specified level of statistical significance, but I think putting together important clinical implications as we can discuss.
Yeah, no, I think that that's incredibly helpful to sort of walk through them. First of all, kudos to you for enrolling a diverse population. That's such a key. I'm glad you started with that. I think that that's such a key focus of contemporary trials, and rightly so. And you know, I think, you know, the other thing that I think is helpful that you highlighted is just the sort of consistency of each of the components of your hierarchical composite. I think that definitely supports a message of the efficacy of that therapy, even though, you know, I think you always go into a trial setting the bar somewhere, saying that we have to achieve this level of effect size to achieve statistical significance. But even if that bar is not met, I think there's often messages or lessons to be learned from trial results. You know, since you went there, I do want to pick up on a thread that you sort of raised, which was this question of you know, sort of qualifying severity of iron deficiency, right? So I think you said that you could get into the trial either by having a ferritin less than 100 or a ferritin in that 100 to 300 range, but with a transferrin saturation of less than 20%. And I think you're right. I was struck when I first kind of when I heard you present the data, and then I read the paper, that the transferrin saturation was a bit higher than I expected. That's sort of the most people kind of qualified based on the low ferritin criteria, and that many patients actually may have had a higher transferrin saturation than many of us might think of as being consistent with severe iron deficiency. And I'll put in a little plug for a scientific statement on iron deficiency and heart failure that you're a co-author on, that was published in JCF earlier this summer, because I think you guys tackle a lot of issues very nicely, but certainly you tackle how we should be defining iron deficiency. So I guess this is sort of a long-winded wind-up to ask you, do you think the patients in HEART-FID really had clinically important iron deficiency across the board, or do you think that there was some variability there? And do you think that kind of variability in the magnitude of iron deficiency, at least as reflected by the transferrin saturation, may have accounted for a slightly more modest effect size than maybe you initially thought you might see?
Yeah, I think you said it really nicely. So as you're alluding to, there are mounting data suggesting that should we be actually ferritin agnostic and just look at the TSAT, and some nice recent data from the Ironman study focused on should we just be using a TSAT less than 20%. Others have suggested there are other biomarkers like soluble transferrin receptors and others that may have a stronger link with clinical outcomes. But at the end of the day, I think based on the evidence we had at the time, I think we chose, and in line with the guidelines, picked that right definition, and now have a number of ongoing analyses in HEART-FID to better understand how this definition may have impacted the results. And to give you a little bit of a teaser, it does look like when we focus on that TSAT less than 20%, that we do see a larger treatment effect. So to be continued a little bit in that space. And I would also note, I think some of this may be related to, in terms of the effect sizes we see, to the COVID pandemic, and in contrast to the earlier studies where they could draw a line in the sand and look pre and post COVID, the majority of patients in our trial were recruited and had follow-up during the pandemic. So I do think that probably impacted this heart failure hospitalization, and then certainly leads to some challenges around acquisition of 6-minute walk distance, how much patients are actually able to walk, as we all reflect back on our own early days in the pandemic and how active or not we were. So I think there were a number of external implications related to the pandemic or otherwise that we're still working to better understand, in addition to the dosing and some of the iron indice criteria as you're highlighting.
Well, thanks, Rob. And you mentioned up front at the beginning that you got into clinical trials to help the patients. And I think the question that all the cardiologists want to know is how can we use this data and in the context of prior studies and prior trials to treat our patients with heart failure? How should we think about using iron replacement therapy when we're on the wards?
Yeah, this is a really important point, and I wish we had a more definitive answer out of HEART-FID, but I think putting in context the totality of evidence now that, well, HEART-FID was designed as that one pivotal trial. In fact, now we've got 3 trials with AFFIRM, Ironman, and HEART-FID. And in fact, in a pre-specified pooled analysis that we did, actually looking at patient level data from CONFIRM, AFFIRM, and HEART-FID, and then the trial level data from Ironman, we do see a reduction in cardiovascular hospitalizations and a numerical reduction in heart failure hospitalizations. So I think putting it all together, we have a therapy that does have cost implications, but particularly on the inpatient side, we can pretty easily check iron stores, iron indices, give this therapy in the hospital, help patients feel function better, and probably have improved clinical outcomes. And certainly there's greater complexity on the outpatient side as we think of testing iron indices and implementing this. And there's a lot to talk through there, just in terms of some of the logistics of giving this IV therapy in terms of different protocols and otherwise. But the key messages that I highlight are, we know the strong association of iron deficiency with worse outcomes. We've got a therapy that's not another pill a patient has to take every day. And importantly, it's been shown to be safe. So we can give this to our patients to help their overall clinical course. And At our institution and many others, I know we're routinely giving this therapy both in the hospital and now increasingly in that outpatient setting based on all of these different trials together.
And is there a preferred formulation that clinicians should use, or is it kind of more of a class effect?
Yeah, this is an important question. There was just a beautiful talk that was given by one of our pharmacists, Stormy Gale, um, at the HFSA meeting, and she gave this wonderful discussion about what are the nuances, the different dosing and frequencies. Certainly, I think we have more to understand around this, but in general, I think there tend to be cost implications, but the greatest data are with FCM. We do now have with ferric durisomaltose in an open label trial in Ironman, those data. But I do think the greatest data are with FCM, but it ultimately often comes down to what's on formulary, cost considerations for the patients and the system. So to be continued, I think a little bit there.
Well, thank you, Robin, and that was awesome. It's always fun to sort of hear it from the horse's mouth, to hear it directly from the trialist. But I have to say that was a real treat. We do have to wind down pretty soon, but before we let you go, I guess I'm hoping we can pick your brain just a little bit more. And as Nick and I were talking about having you on the show, I think one of the things that we were talking about is that one of the things that we really admire about you and what you've done is that, in addition to being a successful investigator, so early on in your career, that you seem to have really embraced opportunities to be, constructively disruptive, right? Both as a trialist and we haven't even talked about this, but sort of also in your role as a journal editor, as the editor-in-chief of the Journal of Cardiac Failure. So I guess my question is what advice do you have for trainees or maybe early career faculty who are interested in bringing creative or innovative approaches to careers in cardiovascular investigation?
Well, thank you. That's a great question. And maybe I talk a little bit about JCF because it's just been such an incredible opportunity. And I think ultimately the advice I would give would be around putting together a team and being part of a team that is in some cases like-minded individuals, but in other cases brings together people that may challenge you, think differently and creatively. And for me, that's what's been so rewarding and thrilling to be part of JCF, where from the earliest days as Anu Lala, my deputy editor, and I put this together, we wanted it to be a diverse group of individuals, and diverse by a number of different ways: men and women, gender identity, race, geography, career of training, discipline. And it was through that that I think we put together this team and created this environment where we were able to challenge each other, hold each other accountable, and think creatively and differently about not only how do we advance academic publishing in this case, but how do we deconstruct and break down some of these things that were exceedingly annoying to us, and let's do things differently to make the experience better for the authors, the readers. So my advice would be around just focusing on diverse views and diverse perspectives and who you're bringing together, and really walking the walk in that. Because, I'd share one recent example where we were on our third associate editor call, and, we were talking about this paper, and I was like, I don't really know if this is going to meet the bar. It's well written, but it's a little bit outside of our scope. And one of our associate editors, who's a nurse clinician researcher, just brilliant individual, Colleen McElveen, said, no, Rob, you're wrong. Like, this is the exact type of stuff we need to advance the science. This isn't your area of expertise. I know that. So to me, that was like just a beautiful example where by having these different views, empowering them to speak their minds, I think it makes us better. So for those early career or anybody that's in this clinical research space, I'd say surround yourself by different views and be willing to listen, because that's what's really thrilling. And maybe to kind of bring it back to how I started this discussion, which has just been phenomenal with you all today, this idea of mentorship. And I've been so blessed to have phenomenal mentors. I try to take each of the things that I love and really respect from each of them and then pay it forward. So that at my kind of mid-career stage now, I'm trying to really elevate and the next generation, but also importantly learn from them. So I like to say to my mentees that, when you've got a great idea and I might shoot it down initially, keep challenging it, because it's really that the brilliant young minds that are going to drive us to do great innovative things moving forward.
Well, thank you so much for those insights, Rob. This has been just an awesome discussion from trials to kind of career advice. Really have loved having you on and want to thank you for taking the time to join us today.
Yeah, thank you so much, and congrats. I mean, this is just a phenomenal forum, and I know this will continue to grow in terms of your listeners and continued amazing content. So kudos, keep it up.
Thanks, Rob. Well, Nick, I have been excited for the return of TIMI Talks, and I have to say, I think that this interview got me even more excited.
For sure. It's really good to be back. And Rob was an excellent first guest on, really a dynamic speaker. And I learned a lot from him today. I feel very well equipped to discuss IV iron supplementation on rounds when residents bring it up, as they always do. And I'm really excited to hear about the additional analyses coming down the pipeline that they have planned. So really overall, awesome discussion.
So this is you're getting at the real reason that we do this podcast, which is so you have your cliff notes going into rounds, so that
exactly
you can.
I'll re-listen on my way into rounds.
Exactly. Got to impress all the trainees. No, I think that it's exactly right. I mean, I thought Rob was great, and it was helpful to hear also just about additional analyses that might be coming down the pike, and we always learn more about trials as we dig deeper into those data sets. So, I mean, a lot of exciting things lined up for this fall. I think without foreshadowing too much or giving too much away, I guess I'll keep the lineup. I won't divulge the whole lineup, but we really do have a great lineup planned for TIMI Talks this fall, including coverage of the upcoming American Heart Association Scientific Sessions, which is just in a couple weeks in November.
Yes, coming up quick. I can't wait, and I hope we see many of you there. So until next time, from TIMI Talks Podcast, this is Nick and David signing off.
Thanks for listening. The TIMI Talks Podcast is hosted by Dr. David Berg and Dr. Nick Marston, and produced by Kate Brennan. Like and follow us on Apple Podcasts, Spotify, and Google Podcasts, and follow us on Twitter @TIMI Study Group to be informed about upcoming episodes.